Before we can study disease, we absolutely must understand health. And that brings us to normal hemostasis. This is the body's precise, healthy process to stop bleeding. It's perfectly balanced, and most importantly, it's strictly localized to the area of injury. Think of normal hemostasis as your body's blueprint for healing. Now you might be wondering, does it all just happen at once? It doesn't. It occurs in a highly specific sequence. Right after a vascular injury, your body triggers a cascade of events broken down into 4 distinct phases, and each phase entirely relies on the success of the one right before it. Here's our high-level roadmap. Step 1 is arteriolar vasoconstriction. This simply means the blood vessel narrows. Step 2 is primary plug formation. This is where platelets gather at the injury site. Step 3 is secondary fibrin deposition. A secure mesh forms right over those platelets. And finally, Step 4 is stabilization and resorption. The body actively controls the clot and begins the healing process. Let's zoom in and look at these steps a little closer. Initially, when the blood vessel is injured, it secretes a substance called endothelin. Endothelin is a highly potent vasoconstrictor. It instantly reduces blood flow to the injured area. Simultaneously, the broken vessel exposes subendothelial von Willebrand factor as well as collagen. Platelets bind to these using specific receptors, like GPIB, and this binding triggers a dramatic event. The platelets change shape. They go from smooth, flat discs to spiky plates. They then release granules packed with ADP and thromboxane A2. These chemicals act exactly like a distress signal. They recruit even more platelets to the area. Together, they form the primary hemostatic plug. The process then continues seamlessly into Step 3. The injury exposes a critical protein called tissue factor. Tissue factor initiates the famous coagulation cascade. This complex chain reaction generates thrombin. You can think of thrombin as a pair of biological scissors. It cleaves circulating fibrinogen into insoluble fibrin. This creates a really strong mesh. It literally cements that primary plug right into place. Finally, in Step 4, the body has to limit this spread. We don't want the clot growing forever, so adjacent healthy tissue releases tissue plasminogen activator, known as TPA, along with thrombomodulin. These molecules stop the clot from growing further, and eventually they help resorb the clot entirely as the surrounding tissue repairs itself. So that beautiful, perfectly orchestrated process is hemostasis. But what happens when that exact system breaks down? We arrive at this critical definition. Thrombosis is the inappropriate activation of hemostatic mechanisms occurring within intact, uninjured blood vessels. We must now ask a very important question. Why does this system fail? In medicine, we trace this catastrophic failure back to 3 root causes, known as Virchow's Triad. The entire foundation of this pathology is brilliantly illustrated by this triangle. It outlines the 3 primary abnormalities that lead straight to thrombosis. They are endothelial injury, alterations in normal blood flow, and hypercoagulability. Let's carefully examine the first node. We'll do this by comparing a healthy endothelium with a dysfunctional one. Now, physical trauma can obviously cause injury, but so can invisible factors. Everyday toxins like cigarette smoke or metabolic abnormalities like high cholesterol damage that delicate vessel lining. When the endothelium is injured, its behavior completely shifts. It stops making vital anticoagulants like protein C and thrombomodulin. Instead, it starts producing procoagulant markers. The blood vessel itself actually begins to invite a clot. Let's pause right here for a moment. I want to emphasize a critical rule. Endothelial injury is the absolute most important factor in thrombus formation. It is the primary driver. This is especially true in the heart and in arterial circulation, where your blood is flowing very, very fast. This second node of the triad involves the physical flow of the blood itself. Healthy blood flows in smooth, laminar streams. But when that flow is disrupted, danger arises. In our arteries, turbulence is the primary culprit. It drives arterial clots by causing direct physical injury to the endothelium. Conversely, in our veins, stasis occurs. Stasis simply means the blood pools and stops moving. This is a massive driver for venous clots. Clinical conditions like aneurysms or an irregular heartbeat like atrial fibrillation severely disrupt normal flow. They end up trapping activated clotting factors and platelets right against the vessel wall. The third node is hypercoagulability. This is an abnormally high tendency for the blood to clot. It can be primary, meaning it's genetic. Common genetic mutations include factor V Leiden. This specific mutation stubbornly resists being turned off by protein C. Another common one is the prothrombin gene mutation, which simply creates too much prothrombin. But hypercoagulability can also be secondary, meaning it is acquired during life. Prolonged bed rest, severe tissue injury from surgery or burns, and cancer all drastically increase your clotting risk. There are also highly specialized conditions, like heparin-induced thrombocytopenia or antiphospholipid. This leads us to the morphology of thrombi. You see, the specific environment of the blood vessel entirely dictates the physical appearance of the clot. Before we look at the specific types of clots, we need to define a very important term, the lines of Zahn. These are characteristic laminations inside the clot. They look exactly like pale layers of platelets and fibrin, alternating with dark layers that are rich in red blood cells. Now, what is truly fascinating here is what these lines actually prove. These distinct alternating laminations prove to a clinician that the thrombus formed in actively flowing blood. This is an absolutely critical diagnostic tool. It allows a pathologist to perfectly distinguish a true antemortem thrombus, one formed while the patient was alive, from a simple postmortem clot that just formed after death. The exact anatomy of the blood vessel creates two totally different clot profiles. An arterial thrombus forms in fast, turbulent blood. It ends up being a friable, crumbly meshwork. It's mostly made of platelets and fibrin. We typically see these in coronary, cerebral, and femoral arteries. In stark contrast, a venous thrombus forms in slow-moving blood. It forms a long, cohesive red cast of the vein itself. It is absolutely packed full of trapped red blood cells. These most often form in the deep veins of the leg. Beyond arteries and veins, there are two more specialized shapes we really must understand. First are mural thrombi. These are massive clots that stick directly to the walls of the heart chambers or the wall of the aorta. They are usually triggered by abnormal heart contractions or underlying atherosclerotic plaques. Second are vegetations. These are clots that form directly on the delicate heart valves. Sometimes they are infected, caused by bacterial endocarditis. Other times they can be completely sterile, caused by hypercoagulable states like systemic lupus erythematosus. We know exactly how a clot forms, and we know what it looks like. But what is its ultimate fate? If a patient survives the initial formation of a thrombus, the physical mass of the clot is going to undergo some changes. Over time, the thrombus will undergo one or more of 4 distinct transformations. The body constantly interacts with the mass, the blood flow interacts with the mass. It's a highly dynamic, shifting situation inside the vessel. Let's elaborate on each of these 4 possible fates very carefully. First is propagation. This simply means the thrombus accumulates more platelets and fibrin. It grows larger and it becomes more dangerous. Second is embolization. This is highly dangerous. A fragment of the clot breaks right off. It travels downstream to block a smaller, distant vessel. Third is dissolution. Through fibrinolysis, the body actually manages to shrink and dissolve a recently formed clot. Finally, organization and recanalization. In older clots, the body will actually grow new capillary channels right through the fibrous mass. This is the body's desperate attempt to restore at least some blood flow through the blockage. All of this detailed cellular biology ultimately leads us directly to the patient's bedside. We arrived at the clinical features. The physical location of the clot and whether it stays put or travels ultimately decides the patient's symptoms. Let's compare these clinical outcomes side by side. In venous thrombosis, a clot in the deep leg veins causes localized swelling and pain. But Critically, 50% of these cases are completely asymptomatic. They're only discovered when a piece breaks off and travels to the lungs. This is known as a pulmonary embolism, and it's often fatal. Conversely, in arterial thrombosis, clots instantly block critical organs. This immediately causes a myocardial infarction, a heart attack, or a stroke. Finally, consider the catastrophic state of disseminated intravascular coagulation, or DIC. This is a widespread microscopic clotting event throughout the entire body. The body rapidly uses up all its platelets and clotting factors. Paradoxically, this massive clotting event results in severe, uncontrollable bleeding. Let's bring all of these distinct concepts together into one master synthesis. We start at the beginning with Virchow's Triad. Endothelial injury, abnormal flow, and hypercoagulability are our triggers. These triggers interact with vessel mechanics to create specific physical morphologies, those friable arterial clots or the long venous red casts. Ultimately, these physical forms lead directly to life-threatening clinical endpoints. Complete occlusion leads to heart attacks and strokes. Embolization leads to respiratory collapse.
First, we need to define an embolus. An embolus is simply a detached mass inside a blood vessel. It breaks free from the vessel wall. This mass can be a solid piece of material, it can be a liquid, it can even be a pocket of gas. Once it detaches, it is carried by the flowing blood. It moves continuously through the circulatory system. It travels away from its point of origin to a distant site. It keeps moving forward freely. It only stops when the blood vessel becomes too small for it to pass. At that point, it is permanently stuck. Okay, let's dive into the anatomy of this blockade. Imagine the blood flowing smoothly. Then, the vessel tapers. It becomes narrower and narrower. The traveling mass gets wedged tightly inside. This creates a severe blockade. We call this a partial or complete vascular occlusion. The blood simply cannot flow past this physical obstruction. This stoppage leads directly to ischemic necrosis. Ischemic necrosis is tissue death. It happens because of a profound lack of blood flow. The surrounding tissue is starved of oxygen. It lacks vital nutrients. Because of this, it rapidly undergoes infarction, meaning the tissue dies.
So where do these traveling masses come from? The vast majority are what we call thromboembolisms. A thromboembolism is a dislodged fragment of a blood clot. The original clot physically breaks apart under the stress of flowing blood. Those fragments float away into the current. This specific mechanism causes almost all emboli. But there are also non-thrombotic types. These are quite exotic. Sometimes, fat droplets enter the bloodstream. Other times, nitrogen or air bubbles get trapped inside. We can even see cholesterol debris breaking free from damaged arteries. Occasionally, bits of tumor or bone marrow enter the blood. Even foreign bodies injected into a person can become emboli.
Now, let's track the most common type of embolus. We will follow a thromboembolism as it moves directly toward the lungs.
Pulmonary emboli present a massive clinical challenge. They are a major cause of sudden death. Over 95% of pulmonary emboli originate deep in the legs. They start out as a deep venous thrombosis. We commonly refer to this as a DVT. A fragile fragment dislodges from the deep veins in the lower extremities. The venous return carries this fragment upward. It moves through progressively larger veins in the abdomen. It travels straight into the right side of the heart. It passes right through the heart chambers without stopping. Finally, it shoots out into the pulmonary arterial vasculature. There, it lodges firmly inside the lungs. Sometimes, this creates a massive structural blockage. We call this a saddle embolus. It physically straddles the main branching point of the pulmonary artery. It blocks both the left and right branches at the exact same time. This halts blood flow to both lungs instantly. Now, smaller emboli can pass deeper into the tiny pulmonary branches. Often, multiple smaller emboli occur over a period of time. If we look at these vessels under a microscope, we frequently see delicate, bridging fibrous webs. These webs are the physical remnants of organized, older clots. They prove that previous silent emboli have actually healed directly into the vessel wall over time.
The clinical consequences of these emboli vary quite a bit. Between 60 to 80% of pulmonary emboli are actually very small. They are completely silent. The patient feels absolutely nothing. The microscopic clot just incorporates into the vessel wall and dissolves. However, large obstructions are incredibly deadly. If an embolus blocks 60% or more of the pulmonary circulation, the heart physically cannot pump. The right ventricle tries to push blood against an immovable wall. The heart muscle exhausts itself very quickly. This causes sudden death or acute cardiovascular collapse. This sudden catastrophic failure of the right heart is medically known as cor pulmonale.
Let's walk through what happens to the affected lung tissue itself. The lung is anatomically unique. It has a dual blood supply. It gets unoxygenated blood from the pulmonary arteries, but it also gets oxygenated blood from the bronchial arteries. Because of this backup system, an embolus in a medium-sized artery usually just causes a hemorrhage. It causes localized bleeding rather than immediate tissue death. The intact bronchial circulation provides just enough oxygen to keep that tissue alive. Infarction, which is true irreversible tissue death, only happens if that alternative bronchial supply is already failing. This might happen if a patient has underlying left-sided heart failure. Alternatively, if the embolus lodges deep in a tiny dead-end branch, no backup blood can reach it at all. That leads directly to a pulmonary infarction. We will now shift our focus away from the venous system. Let's look directly at the arterial circulation.
Systemic emboli are different. They travel exclusively in the arteries. What is highly significant here is their precise origin point. Unlike venous emboli, they originate primarily from inside the heart itself. About 80% of systemic emboli come from intracardiac mural thrombi. These are massive, dangerous clots forming inside the heart chambers. 2/3 of these mural thrombi are specifically linked to left ventricular wall infarcts. The heart muscle dies and a clot forms right over the dead tissue. Another 1/4 of these are linked to left atrial dilation and fibrillation. The heart fails to pump smoothly. The blood pools inside the atrium. The stagnant blood forms clots. Eventually, the heart ejects these clots out into the systemic body.
Once these emboli leave the heart, they can travel almost anywhere in the arterial system. About 75% of these arterial emboli rest in the lower extremities. Another 10% travel upward and lodge in the brain. They also frequently hit the intestines, the kidneys, and the spleen. The primary physiological consequence here is tissue infarction. The downstream tissue dies from strict ischemia, or lack of blood. The severity of this damage depends strictly on 3 crucial factors. First, the tissue's biological vulnerability to oxygen deprivation. For example, neurons in the brain are highly sensitive and die in minutes. Second, the anatomical size of the blocked vessel. A larger vessel blocks more downstream tissue. And third, whether a collateral blood supply exists to rescue that starving tissue. The crucial takeaway here is understanding this fundamental anatomical divide. The trajectory of a traveling clot is dictated strictly by which side of the vascular system it starts in. Venous emboli originate in the deep systemic veins. They travel directly to the lungs. They specifically threaten the pulmonary circulation and the right side of the heart. On the other hand, arterial emboli originate in the left side of the heart. They travel away from the heart through the aorta. They threaten the rest of the peripheral body. They cause severe distal tissue necrosis in places like the brain, the bowel, or the lower limbs.
Beyond blood clots, we must also examine severe, non-thrombotic emboli. These have entirely different origins.
First is fat embolism syndrome. This severe condition typically follows massive physical trauma. Most commonly, it happens after crushing fractures of long bones, like the femur. The center of your bone marrow contains vast amounts of fat. A traumatic injury physically ruptures the nearby veins. This allows adipose tissue, or fat, to forcefully push into the open bloodstream. This creates fat globules that travel straight to the lungs and brain. They cause mechanical obstruction of the tiny microvessels, but they also cause a dangerous biochemical toxic injury. Free fatty acids are released. These severely damage the delicate inner lining of the blood vessels. Symptoms usually appear 1 to 3 days after the physical injury. Patients experience sudden lung insufficiency, severe neurologic issues, and a distinct petechial rash on their skin. They also develop thrombocytopenia. This means they have abnormally low platelets circulating in their blood. To actually see these fat globules under a microscope, standard methods do not work. The fat simply dissolves. Pathologists must use specialized fat stains to identify these lipids.
Next, let's examine air embolism. Gas bubbles can accidentally enter the blood circulation. They form dangerous, frothy masses that completely block normal blood flow. This physical blockage happens when a negative pressure gradient actively sucks outside air into the vasculature. We commonly see this during invasive surgeries or traumatic chest injuries. A highly specific variation of this is decompression sickness. This dangerous condition affects deep-sea divers who ascend too rapidly to the surface. Nitrogen gas safely dissolves in the blood under high deep-water pressure. But if the ascent is too fast, that nitrogen suddenly comes out of the blood as expanding bubbles. This rapid expansion causes strict, painful clinical syndromes. Expanding gas trapped in the skeletal muscles and joints causes extreme, agonizing pain. We call this the bends. Bubbles accumulating in the delicate lungs cause acute pulmonary edema and severe respiratory distress. We call this the chokes. Over extended periods of time, persistent gas emboli can cause chronic, localized bone necrosis. We formally call this long-term damage caisson disease.
Another exotic type is amniotic fluid embolism. This is a devastating complication of labor. It is very rare, but it carries a catastrophic maternal mortality rate of up to 80%. Fetal squamous cells, hair, and amniotic fluid forcefully enter the maternal veins. This happens through microscopic tears in the placental membranes. The resulting damage is not primarily mechanical, it is profoundly biochemical. The foreign fetal fluid triggers a massive, overwhelming maternal immune and coagulation response. The mother suffers sudden, extreme difficulty breathing, circulatory shock, and seizures. This rapidly leads to disseminated intravascular coagulation. We routinely call this DIC. DIC is widespread, dangerous clotting throughout the entire maternal body. It rapidly consumes all available clotting factors. Because all the clotting factors are used up, this systemic clotting paradoxically causes uncontrollable, severe internal bleeding.